안녕하십니까. 더닥터 신문의 이상동 기자입니다. 오늘 이 자리에는 독일 비판테스 노이켈른 의료원의 헤럴드 다리우스 교수님이 함께 하셨습니다. 다리우스 교수님은 신장학 분야의 세계적 석학이십니다. 특히 신규 항응고제 다비가트란 승인의 근거가 된 릴라이 임상연구에 참여하시는 등 현장 진료와 함께 활발한 연구활동을 펼치고 계십니다. 오늘 저희가 논의하고자 하는 심방세동 환자의 뇌졸중 예방, 이 분야는 획기적인 항응고제의 등장으로 새로운 전기를 맞고 있습니다. 직접 트럼빈 억제제 다비가트란, 직접 팩터 10A 억제제 리바록사반, 아픽사반 등이 대표적인데, 이 가운데 다비가트란은 신규 항응고제 중에서 가장 먼저 심방세동 환자의 뇌졸중 예방에 승인되면서 미국과 유럽을 비롯해 전 세계적으로 다량 처방되어 왔습니다. 오늘 다리우스 교수님과 함께 심방세동 환자의 뇌졸중 예방 전략, 특히 다비가트란을 중심으로 신규 항응고제의 임상 경험에 대해 집중 논의해 보도록 하겠습니다. Dr. Darius, thank you for being here today.
Oh, welcome, my pleasure.
Today, I'd like to talk about the strategy of stroke prevention in patients with atrial fibrillation, because you were one of the investigators of the RELY trial, and because with that trial, dabigatran has already been approved for stroke prevention in patients in atrial fibrillation in Europe. So I also want to talk about your clinical experience of dabigatran in Europe. So before we get into anticoagulation, could you tell us about the current status of atrial fibrillation in Europe? I mean, I'd like to know about the size of the population in Europe and what is currently known about atrial fibrillation.
Well, the problem of atrial fibrillation is rapidly increasing in Europe. The number of patients is definitely increasing because we know that there is an increase in the prevalence of atrial fibrillation with age. Our population is aging rapidly, and so we have a rapidly rising number of patients who have atrial fibrillation, specifically elderly patients over the age of 80 or 85. And in Germany, we estimate that about 250,000 people do have atrial fibrillation, and of these, about 200,000 may have an indication for oral anticoagulation. And thus far, the oral anticoagulation has been done with a warfarin-like drug called fenprocamone, and we have the same problems that all the other nations have, which is undertreatment and poor control of the anticoagulation level, due to the many side effects and problems of vitamin K antagonists, as there are food and drug interactions, for example.
Okay, and atrial fibrillation is one of the leading causes of stroke. And if so, what are the primary risk factors of stroke in patients with atrial fibrillation? And I also wonder why the stroke in patients with atrial fibrillation is more fatal and severe.
Yeah, it's true that atrial fibrillation is one of the major risk factors for stroke, that the estimation is somewhere between 20 and 35% of all strokes are due to cardioembolism due to atrial fibrillation. And one of the problems is that very often we don't detect the atrial fibrillation. If the patient doesn't notice it, then very often the stroke is the first symptom of atrial fibrillation in a patient. And it also occurs very often that patients are on a stroke unit after their first stroke, and the atrial fibrillation is not readily detected, but only in a couple of days of ECG observation. Atrial fibrillation is detected as a primary cause of this stroke. The problem of the atrial fibrillation-associated strokes is that they're very severe, that mortality and morbidity of these strokes is very high, probably because these are old thrombi that have resided in the heart for days, maybe weeks or months, and suddenly they're dislodged and going to the brain. And they are not really susceptible to thrombolytic therapy, or very often the success of thrombolytic therapy is very poor in these patients. So high mortality, it's estimated that over 25% mortality, which is high for stroke, and a high degree of handicapped patients afterwards. So the modified ranking scale, the scale with which you measure the handicapped status of the patient, is very high in these.
Okay. And so what is the standard treatment recommendation for atrial fibrillation patients? And what was the most difficult part in those treatments?
Well, the standard recommendation for the treatment of atrial fibrillation is on the one side, of course, the rate reduction or rate control of therapy, and on the other side, the anticoagulation. So far, until last year, aspirin was also recommended for low-risk patients, and then vitamin K antagonists for the high-risk patients. In the newest guidelines of the European Society of Cardiology, for example, for atrial fibrillation treatment and prevention of strokes, it's said that only the very low-risk patient with a CHED score of 0 or 1 should either get nothing or they may receive aspirin, but the CHED score of 2 or more, they definitely should receive oral anticoagulation. So far, this was the vitamin K antagonist, but since mid of this year, we were able to provide our patients with a much better improved principle of anticoagulation, which is the thrombin antagonist, the dabigatran taxilate.
Okay. And as you mentioned before, I have been informed that improper use of medication by patients, for example, as you mentioned, many limitations such as the need regular monitoring and various food to drug and drug to drug interactions is another explanation of mismanagement of stroke in patients with atrial fibrillation. So, do you have any opinion on that?
This is true, yeah, that the therapy with vitamin K antagonists has many limitations. First of all, we do have a very high inter-individual susceptibility to warfarin. Some patients need very low doses, some patients need extreme high doses depending on their vitamin K metabolism. And we have this high influence of drugs and food on the availability of vitamin K and on the efficacy of vitamin K antagonists. And therefore, we always have to measure the level of anticoagulation just to adapt the patients to these interactions. And we have the slow onset and slow offset of efficacy. If we decide to put the patient in anticoagulation, it sometimes takes 3 to 5 to 7 days to reach a sufficient anticoagulation level, which is an INR between 2 and 3. And if we look at at some of the statistics and some of the studies, then only about half of all patients on anticoagulation with vitamin K antagonists are really in the therapeutic range between 2 and 3, and most of them are either under anticoagulated or some of them are even over anticoagulated, which carries a very high risk for cerebral hemorrhage.
Okay. So as you mentioned, currently we have the newly approved anticoagulants for stroke prevention in atrial fibrillation patients. So what are the expected effects and roles of the new agents compared to warfarin?
Well, we would expect that with the new agents it's much easier to anticoagulate a patient constantly because there is no necessity for dose adaptation anymore. There's no necessity for regular measuring the anticoagulation level, for regular monitoring the anticoagulation level. And so it's much easier for patients specifically if they are traveling, for example, if they have some other health problems in addition to that. So we can expect that the level of anticoagulation will be much more stable. And therefore, we also would expect that that more patients which we right now don't anticoagulate can be anticoagulated in the future, specifically those where we were afraid of bleeding complications, because we know that with the dabigatran, for example, the number of bleeding complications, specifically the intracerebral hemorrhages, is decreased significantly. So the number of patients will be increased and the quality of anticoagulation in those on drug will be increased.
So with the new agents, what kind of additional education or specific information would patients and physicians need in the clinic?
Well, the additional information that's necessary for the treatment with the new drugs is that, of course, these drugs are effective anticoagulants, so patients may bleed. This is natural for an anticoagulant. And there are some factors that have to be taken care of. For example, patient's weight, patient's age, and renal function. With the dabigatran, if we take that as an example, it's known that dabigatran is excreted by the kidney by about 80%. So in patients with renal disease or suddenly deteriorating renal function, this may cause a problem. And therefore, there are the recommendations that prior to starting therapy with dabigatran, renal function should be checked. And the approval is for patients with a renal function with a creatinine clearance between 30 and normal, so only down to 30. And if there is a sudden situation that may cause a deterioration of renal function in patients, like elderly patients with diarrhea, with execosis, with fever, pneumonia and so on, then renal function should be checked in order to avoid over-anticoagulating patients due to the fact that their renal function may have been deteriorated in the meantime.
Okay, let's get more focused on dabigatran. So patients are required to take dabigatran twice a day. And what's the difference between taking one dosage daily and twice a day? In my knowledge, FDA has showed concerns about one dosage daily in efficacy and safety. And what are your opinions on that?
Well, the twice daily dosing was a point of very long discussion in the steering committee prior to starting the study, because the long half-life of the drug, 14 to 17 hours in elderly patients, theoretically would allow to take the drug once daily, but due to the fact that we wanted to have the plasma level without too much fluctuations, we choose to give the drug twice daily. This is specifically in the cohort with atrial fibrillation, the elderly patients who very often have other diseases too, hypertension, Parkinson's disease, whatever. They very often take medication twice, so this is not considered to be a major problem, to be a compliance issue in these patients. With the two doses that are approved in Europe, for example, the 150 and 110 milligram, we are very happy with that with a specific patient's cohort, we can take a lower dose, but the regular dose. The regular dose in almost all patients should be 150, but in those over the age of 75, for example, with other risk factors for bleeding, we have the chance of taking the 110 milligram. In the United States, the situation is different. There, the FDA forces doctors to take the higher dose, because only the 150 is approved. The higher dose, which is significantly better than the well-controlled warfarin in the RELY trial. And the lower dose of 110 was only non-superior to warfarin. So, but in addition to that, the FDA expanded the range of patients which may get the drug down to a creatinine clearance of 15. So for patients with a creatinine clearance between 16 and 30 ml per minute, the FDA approved 75 milligram twice daily, despite the fact that the 75 milligram never have been tested in a clinical trial. So we don't have efficacy data for that. This was only based on pharmacokinetic study data.
Okay. So when was dabigatran approved in Germany, and what is the exact implication of such an approval?
Well, dabigatran was approved half a year ago and, for the treatment in the European Union. It was not brought into the market in all countries because there are some price negotiations and so on. But patients were very happy with the drug because many lay press journals and so on reported about this improved method of anticoagulations. There was a true run of patients to the doctors to ask them if this wouldn't be a better way to anticoagulate them. And also in my outpatient office, there were a lot of patients coming and asking me if the new drug wouldn't be something better for their anticoagulation therapy than the warfarin or the fenprogamine, which we usually use.
Okay.
So there are major implications for the daily treatment of the patients.
And dabigatran is the first developed anticoagulant that has been largely used to prevent stroke prevention in patients with atrial fibrillation. And I wonder, European or German guidelines say anything about prescribing dabigatran?
Yes, there are a couple of scientific bodies, like for example the European Society of Cardiology, whose guidelines are also accepted by the German Cardiac Society, that do recommend the treatment with dabigatran as superior to the vitamin K antagonist treatment. And the same is true for the US-American guidelines. There are also the combined guidelines of the American Heart Association and the American College of Cardiology do recommend the treatment with dabigatran for prevention of strokes in AFib patients.
And dabigatran has been in use for about a year now. So, and as a physician prescribing the drug, do you have any perspective you'd like to offer on the application of the drug? Yeah, in Europe it's used since half a year. In the United States it's used since almost 1.5 years.
And if my information is correct, we have accumulated so far 410,000 patient years. And the experience with this large group of patients treated for 410,000 patient years is a very good one, despite the fact that some side effects have occurred. When talking about the dyspepsia, which showed up in the RELY trial, in clinical practice this does not seem to be a major problem, because when we started RELY we did not know that intake of the drug with food or after a meal decreases the incidence of this dyspepsia significantly, and that also PPIs, so protein pump inhibitors, are able to alleviate the patient's symptoms. The other fact is the bleeding complication rate, which has been reported, for example, in Japan and Australia. That there were some cases of fatal bleedings, and this was mainly occurring in patients with a very low body weight. Some Japanese patients were reported to have a weight of 40 kilograms. In very old patients, the oldest patient was 100 years old, and even in patients on hemodialysis. So this is a special patient cohort where special caution should be used in prescribing dabigatran because of the low body weight, because of the old age, and the probably deteriorated renal function in this old age. And for patients on hemodialysis, it definitely was contraindicated, because also in Japan it was approved only down to creatinine clearance of 30 ml per minute. There are a lot of calculations now to compare the bleeding rate in RELY with the bleeding rate that occurred during the everyday use. And if you see how many bleeding, fatal bleeds and severe bleeding complications have been reported to the administrative bodies, it's only 1/4 or 1/5 of those that would be expected according to the results of the RELY trial. So in real life, bleeding is definitely much lower bleeding rate as to be expected from the RELY calculations, if you calculate this per 100,000 patient years. So there's a very convincing calculation with that. Okay. So the practical experience with the new therapy is a very positive one.
So in the RELY trial, dyspepsia was the only adverse effect that was more common with dabigatran than with warfarin. So how was the dyspepsia in the clinic?
Well, a few patients whom I prescribed dabigatran complained of dyspepsia, but when I told them to take the drug either with a meal or after a meal, then the dyspepsia disappeared, and it occurred only during the first weeks of therapy. Somehow, after 2 or 3 weeks of therapy, the patients don't complain about dyspepsia anymore. So this seems to be a phenomenon that's there, but that doesn't hinder patients to take therapy regularly.
Okay. And there remains another issue that needs to be addressed when you talk about new agents introduced into the market. I mean, cost is a significant motive for consumer purchases, and I presume that the newly developed agent will be more expensive than warfarin. So, what do you have any opinion on that? And do you have any information on the cost-benefit analysis performed regarding the dabigatran?
Unfortunately, your assumption that the new drugs will be much more expensive than the warfarin is correct. And but you have to see that you differentiate between the pill price, which is much higher for the new drugs, also for dabigatran compared to warfarin, and the so-called process costs or total costs for the health system. If you see the warfarin costs per pill are very low, but you have to add to that the costs of regular monitoring, the time and the coagulation testing, and the tremendous costs of the additional strokes that occur, and specifically the hemorrhagic strokes that occur. We talked about it that atrial fibrillation-associated strokes have a very high morbidity too, and a very high degree of handicapped patients afterwards. So there are tremendous costs that can be saved for the health system. And there are calculations done in our health economical evaluations done in Canada and the United States. There are 3 studies published so far, and they all show identically that the costs for the health system are substantially decreased, despite the fact that the single pill is much more expensive.
Okay. And for the final discussion, with the newly approved dabigatran, what is the future projection of warfarin? Do you think it will continue to play an important role? Or, will warfarin become outdated, or will it be still useful?
Well, my very personal opinion is that probably within the next 2 years, almost all patients will have switched to the new therapeutic principle, to dabigatran or factor Xa antagonist, because of the ease of therapy, the safety of therapy, and the benefits of the new drugs. But of course there are other indications outside of atrial fibrillation, anticoagulation, where the warfarin definitely still is needed. Indications, for example, where none of the new drug has been tested yet, like artificial heart valves. So the vitamin K antagonist still will be around, but the number of patients taking vitamin K antagonists will decrease significantly.
And how about aspirin in terms of preventing stroke in atrial fibrillation patients?
That's a very interesting question with the aspirin, because so far aspirin was regarded as being sufficient for low-risk patients. And in the older guidelines, aspirin is recommended for patients without or with one CHED2 point. In the newer guidelines that appeared last year, the newer European guidelines that appeared last year in September, the aspirin is almost regarded as placebo, and these guideline recommendations are being revised and will be published next summer, and then aspirin probably is not recommended anymore for the prevention of stroke in patients with atrial fibrillation because the effect is not proven.
Okay, thank you for taking your time with us today.
You're very welcome.
Thank you.